Good morning and welcome to COVID Talk with local health authorities. With us representing Harris County is Dr. Erica Brown. With us representing the city of Houston, Dr. David Purse. Special thanks to Morgan Ash and David Castillo, who are our co-producers today, and past President Kathy Finninger of Rotary Club of Houston. I'm Stephen Williams, the director of the Houston Health Department. First question. Texas Medical Center reported a RT amount of 1.26 up from 0.07 the week prior. Are you seeing the same increase in wastewater?
So I'll take that one. It's a wastewater question, and actually the TMC RT value went up to 1.6, but it went up from 0.97. But it did go up, and one thing I'm not a big fan of RT because I don't know exactly how it's calculated, but it's been pretty reliable. And everybody knows if the value is greater than 1, it means that the virus is spreading in the community. But there's a little bit of a lag. And so actually this last week, we saw the wastewater come down. It went from 112% the week before down to 91%. So that's a relative decrease of 19%. It's a pretty sizable decrease. So I anticipate we'll see the RT drop over the coming weeks, as well as positivity rates and some of the others. So yes, there's your answer to that.
So how are you explaining the dynamics of this up and down?
Well, I think, it's a wave phenomenon. I think that there's a couple of things. One is, there are a lot of things that we as community members can do to influence how much the virus spread. And we saw that in previous waves. And when the numbers started increasing and people started putting on their masks and social distancing and so on and so forth, especially 2 years ago in the beginning, it changed the direction of the pandemic locally. And then the numbers would come down and we would get lax, and we would take the masks off and so on and so forth. Guess what? It would come back again. But there's also this sort of, in my opinion, my theory is that there's a little bit of a harmonic wave pattern that occurs with pandemics we don't fully understand. And I think that's what we're going to continue to see moving forward. But right now we're in a community where we've got a good number, not enough, but a good number of people are vaccinated. We've got a number of folks who have been previously ill and have got some immunity. And so we're going to see this wave phenomenon, I think, continue, because I think there's just something inherent with pandemics that causes it.
Harris County Public Health shows the positivity rate is 5%. Reported cases in the U.S. have risen 50% in the last 2 weeks. Hospitalizations and death have increased, also according to the Times database. Please comment on the significance locally.
So I think Dr. Purse answered much of this question. It really goes in waves. Who knows whether we're going to see this wave hit our area, but for right now, our numbers are lower than, especially on the northeast side of the country, our numbers are lower. So it's just a wait and see game, unfortunately, on what our next numbers will look like, because it does go in waves.
How much is at home not reported testing affecting how much we really know about our present COVID situation in the area?
Yeah, so, I'll tell you, this is a really great question. In fact, Dr. Brown and I just got off an hour-long conversation with our colleagues across the region, and we spent much of the time talking about the conundrum that this presents for us. And that is that with all this at-home testing, it doesn't get reported. The tests that we do get, that we report on, are the ones that are from our public testing sites. And that means somebody had to go to that public testing site, and perhaps they scheduled it in advance and they went. So that takes more effort, obviously, than testing at home. So the people who did that, a couple of things. One is apparently they don't have at-home testing available to them, and they went for a reason. So they feared that they were exposed to somebody. That means they got a phone call, said, "Hey, I got it, and I was with you yesterday." So there's that. Or they suddenly have symptoms. So there's a bias there. The other group that we have been looking at for testing positivity rate has been the Texas Medical Center, because they do testing of everyone who's getting an outpatient procedure. They test everyone who's getting admitted to the hospital. They have a lot of testing of their employees. So that's a little bit more of a random sample, but even that is not a completely random sample. So the at-home testing really has put a curveball into how much faith we can put into the positivity rates, leaving us really with the wastewater and hospital admissions as the two values that we think are most reliable in telling us, with wastewater, what's about to happen, and with hospitalization, what's actually happening now.
Okay, this one's a little long. Counterfeit at-home over-the-counter COVID-19 diagnostic test on May 5th, 2020. The U.S. Food and Drug Administration issued a warning that counterfeit at-home over-the-counter diagnostic tests for COVID-19 have been distributed or used in the U.S. These counterfeit tests should not be used or distributed. The FDA will update its website to list counterfeit at-home OT over-the-counter COVID-19 tests. Diagnostic tests to alert the public, including tests using caregivers, healthcare providers, and distributors, and to provide information on how to identify counterfeit tests. This was actually just a statement. Have y'all been hearing much about this?
So it is correct that there is information out, and I just want to give a little bit more about the specific tests. So Flowflex test kits, iHeart antigen rapid test kits, and then some of the things to look for. So if the print quality on the box is poor, I mean, we all know what a box you buy from the pharmacy looks like, and so if it's not a good quality print on the box, it potentially is counterfeit. Missing information on the outside label of the box. So for instance, just really quickly, I have an at-home test here. This one came from, this is my government issued test. It has not only the name and things on the front, but on the back, it has a lot number, an expiration date, and then it has some specific instructions for how to use and the do's and don'ts. So again, and I can read every bit of this test, even the fine print. So I think that that's key. And then also looking for grammatical and spelling errors, just like we would look for in phishing things in our spam and things like that on the computer. The same thing applies to these test kits.
Indoor masking in the Northeast is back again. There's suspicion that the number of cases are higher than other ways, but not reported because of home testing. Any predictions on what to expect here?
Yeah, I'll take this. So, one thing I've said recently is in public health, I've come to learn that if you want to make a mistake, make a prediction. So let me go ahead and say that I think that we're going to, right now it looks like with the wastewater having come down, hopefully that will continue. We may be on the downside of the current wave. I think we're going to see more waves in the future, kind of going back to the answer earlier. I think that there's this harmonic wave phenomenon thing that occurs with pandemics that we don't fully understand. Now, the question is, will it get to the point where we're going to have to take a lot of action? So that's what they're doing up in the Northeast, trying to get ahead of it. And that's the other thing is that if you're going to take an action during a pandemic, you need to do it before your problem occurs. And so the actions that we have today are you get vaccinated, wear a mask, social distance. These things really, really work. I was at an event yesterday at municipal courts, and in our municipal court building, masking is still required. And I was talking with one of the gentlemen there who's so happy about that because he takes care of an elder person in his home who has a serious chronic medical problem, and he has not been infected. But our court system our court building has about 2,000 members of the public per day that come and go. And every day there are members of the public coming in and out of that building that don't know it, but they're infected. And here's an employee who's responsible for the health of somebody who's clearly at risk, and he has not yet been infected. So masking works. And so what's going to happen locally? I think that we're going to see more waves. I'm hoping that there are going to be like this current one where we're not going to see a lot of hospitalizations. But if another variant occurs, it could set us all back to square zero.
Vaccine, boosters, antibodies. What can you tell us about a possible second J&J pause?
So I think we need to reframe what we're calling this. It's not a J&J pause. J&J has been very open about one of the known risk factors with it, which is a phenomena of a blood clot. It's a rare risk, but it is a risk with J&J. And so because they have seen a little bit more of an uptick with that, the FDA has decided to put some specific parameters around J&J. So while it is still available, people need to be aware of the risk and they need to specifically ask for J&J. And the reason people would perhaps ask for J&J is if they really have a fear of needles, et cetera. This is a one-shot deal, but now it is required to get a second booster with an mRNA vaccine that's either Moderna or Pfizer in order to complete the primary series. So it's not a pause on J&J, but it's just identification and notification of the potential risk of a blood clot.
So really there's a more defined use for J&J. I read there could be a COVID vaccine storage and shortage in the coming months due to the government stalling funding. Will this affect a new variant-specific booster?
I don't think that it will. The current vaccine that is out and available now was really derived from the original, what we're calling the wild type virus. And so since then, we've had Alpha, we've had Delta, we've had Omicron, and of course, Omicron really now is sort of a family. We've got BA1, BA2, BA2.12.1, blah, blah, blah. So I think that the manufacturers see that there will definitely still be a market for more current, if I can use that term, vaccines that are keeping up with the variants that are occurring. And of course, as time moves forward over the coming years, I think similar to the flu vaccine, it gets tweaked. The flu vaccine gets tweaked every year. We may see that with Omicron. So I'm not anticipating that this is going to interrupt that. Certainly, the pharmaceutical companies that make vaccines, they're there to make money. And so as if there's a market where we're willing to pay for it, then they're going to make it.
Even though the vaccine effectiveness is waning, many doctors are encouraging even their immunocompromised patients to wait until the new vaccine comes out. Are you hearing it is worth waiting for?
So I think this is a complicated question. Number one, we do know that anyone who has had COVID in the last 3 months has some pretty good immunity. So that's one thing. As we talked about in our last episode, there's also the factor of too much vaccine per se, where we're looking at, is there such a thing as overstimulating the immune system? That's number two. So those are things to be considered on an individual basis. The third thing is, as we just talked about in the last question, there are some vaccines in development that are specific to variants, similar to what we do with the flu vaccine, which is we take a look at what is going to provide the most coverage given all of the variants that are out. So again, it's a very complicated question. I think it's one that is a personal question with your clinician, and that there's clinicians have their own personal opinions about that. I don't think there has been anything specifically saying, guidance saying to wait or not to wait. Again, it really is based on your personal circumstances with your clinician. David, did you have anything to add?
No, I think you've summed it up quite well. And the other thing is that not only is it a question about your specific situation, you should have a conversation with your clinician, but also what's going on in the community, right? So if our wastewater had continued to go up, instead of going from 112% to it dropped to 91%, if it had gone up to 183% and we saw that trajectory continuing, that would be a different situation. And I think people would need to take it much more seriously. Again, remember, once you get the shot, it's still another 2 weeks before your immune system is fully responded to that vaccine. So you want to do things ahead of the curve, not be behind the curve. So it's a complicated question.
Related, has your opinion changed regarding second boosters?
So mine has not changed. No, and in terms of boosters, what I'm really focusing on now are the people who didn't get their first booster. We know that if you got your first series, that worked well against Alpha and Delta, but it doesn't work so great against Omicron. Now, what's really interesting and may not be intuitive to folks is that if you get your booster, even though it's the same vaccine, it does seem to give pretty decent protection against Omicron. So the people I worry about most, not the ones who are contemplating getting their second booster, the people I worry about most are the folks who didn't get their first booster. Those are the folks who really have got something to gain right now. And I would encourage them to seriously consider getting your first booster if you haven't gotten that yet.
It's interesting that we're talking about boosters since we know that there's still a significant number of people that are not vaccinated at all.
Well, I wish I could convince them to go ahead and get vaccinated, but I think they've made up their minds. The people who got vaccinated but didn't yet get boosted, obviously they're willing to get vaccinated. And so those are the folks that I fear are not getting boosted because they just don't think it's that, the risk is not there anymore. Well, the risk clearly is still here. There are people still getting hospitalized every day. It's not a huge number, but it's not zero either. And so most of those are either unvaccinated or inadequately vaccinated.
News says the FDA to decide the future of COVID vaccine by June. Is that regarding frequency?
No, it's not. It's really it's not the future of the vaccines. It really is what we talked about in terms of how often should you get boosters, as well as what should the vaccines include in terms of the different variants. So it's not specifically to discuss the frequency. Okay.
Status and success of Sinopharm from China and Abdallah from Cuba.
Yeah, so so let's talk about the Sinopharm from China. It's gotten a lot of bad press. In fact, there was a report this morning that there's an outbreak in North Korea. North Korea has not pushed vaccination because they don't like the Western vaccines. They don't trust the Western pharmaceuticals, and they weren't happy with the effectiveness of the Chinese vaccine. And this is the Sinopharm. And so the thing about it is we got to put this in perspective. Our mRNA vaccines that are available here in the United States have been about 94, 95% effective in preventing severe illness. The Sinopharm is in the 70% range. And so people are saying, well, that's not very good. You got to keep it in perspective. Prior to the mRNA vaccines that came out, any vaccine, whether it be, most of our vaccines that we deal with, in particular flu vaccine, if it's 70% effective, we would have been thrilled. That would have been a great value, a great effectiveness. But the mRNAs being 94, 95% effective and getting so much public attention have sort of, reset everybody's threshold for what is a effective vaccine. So it's not that the Sinopharm is a bad vaccine. It's just, its competition is a whole lot stiffer. The Abdallah from Cuba has good numbers. The one thing I would caution folks is when you read about this, you got to be careful when you read the numbers, because they talk about effectiveness versus getting infected versus getting symptomatic. So infected and symptomatic. And remember, a lot of people get infected and never have any symptoms. And then they talk about people getting hospitalized and then people getting dying from it. So efficacy, depending on how it's described, can be one of four different, either infection, symptomatic infection, hospitalization, or death. And you got to make sure that you're making apples to apples comparison. And so the Cuba vaccine actually appears to be pretty effective. I think it was 90-something% effective against severe illness and hospitalization. And that's a good value. But again, I would warn folks that when you're reading about this, make sure you're doing an apples to apples comparison of the numbers.
Has the FDA approved remdesivir for young children?
It has. So on April 25th, remdesivir for children 28 days and older, and the caveat to that is at least 7 pounds. And so it can be given for those who are hospitalized, as well as those who are not hospitalized but have moderate to severe illness. So yes, it has been approved for young children. What
about boosters for children?
Yeah, I think we had a graphic up earlier on this, but yeah, there are. So for kids, I realize right now I'm confusing this in my own head here. So Erica, save me. So with kids,
so
go ahead. Yeah.
Pfizer submitted a request for boosters for children between the ages 5 and 11, given 6 months after the primary series. So for right now, there is no authorization for a booster for children, but Pfizer has submitted authorization for a booster. But let's not confuse that with the primary series for children, as well as the recommendation of an additional part of the primary series for those children who are immunocompromised. So to David's point, it's just very, very complicated. I would highly recommend that the CDC does a pretty good job at providing an algorithm, a table to this, and it's pretty clear on where you personally or your child personally would fit into that. I would highly recommend taking a look at that, as well as consulting your physician.
Prior to getting a booster, wouldn't it be logical to get tested for antibodies?
So again, this is another one where there's different viewpoints about this. Some theory about it is even though you may have been exposed, so for instance, natural immunity, you've had COVID and you have some natural immunity, there's obviously some benefit to still being vaccinated. And so there's a thought around that about, if the vaccination is beneficial anyway, then why get tested prior to? Just go ahead and get vaccinated. But again, there's different thoughts around it.
Pfizer released a study showing there was mild reduction in symptomatic infections of COVID to close contacts of those positive who took Paxlovid. Please comment.
Yeah, so, Paxlovid works by, combating the virus. And so if you are, a couple of important things. One is we know that I shouldn't say most, depending on where you read, but many people who get infected are infected by somebody who is asymptomatic. So one thing about Paxlovid is that people are generally symptomatic when they start taking it, right? And again, if it's being used properly, these are people who've got high risk factors. And so they may have higher viral loads and able to spread it. And so if you can reduce the viral load in the patient who's taking the Paxlovid, their ability to spread it would go down right along with that. And so this is not a surprise. But remember, again, the reason we're taking the Paxlovid really isn't to reduce the spread. It's to keep that patient from going on to severe illness. Was
Paxlovid tested on unvaccinated? If so, how do we know it works on vaccinated?
That's a good question. It was tested on those who are unvaccinated. These are some great questions. And so, frankly, we really don't have an answer for that. The FDA has authorized it. We have seen some benefit to its use, which I think answers the question about being tested on vaccinated people. The people who it has been used upon have been both vaccinated and unvaccinated, and we've seen some success with it, but it was tested on unvaccinated.
Why does Paxlovid taste like metal?
Yeah, that's a good question. I haven't taken it, so I didn't know that it tasted like metal. I don't know why it tastes like metal.
We don't know, but to your point, David, I have a friend said that was the worst part. I mean, a strong metallic taste. So, but we don't know.
Antibody cocktails, 2 synergistic antibodies neutralize severe acute respiratory COVID. What are they, and how quickly would they have to be given?
So there are 2 types of neutralizing antibodies that are being studied and found to be effective. As far as how quickly would they have to be given, I don't know, David, do you have more information on this? I know that there are studies that are ongoing, so I don't have a specific answer to that question yet. Again, this is something that's being looked into, and we probably can provide more information at a later date.
Yeah, I don't have anything to add other than just like with all these interventions, if you're a person who's at high risk for having a severe complication, the sooner you get treated, the more likely you're going to have a beneficial impact from the medication.
Okay, we have about 5 more minutes, and I think I have 10 questions. So, infection rate comparison with vaccinated and unvaccinated appears to be getting closer. Please explain.
Yeah, so I'd be interested in seeing where that's coming from, but it makes sense to me that might be the case because in our community, more especially after Omicron, there's so many people who got infected and perhaps didn't even know it, who have now developed some level of immunity. So whether you were vaccinated or unvaccinated and became infected, you've now got some level of immunity. So that's going to cause the disease behavior to flatten out. Whereas a long time ago, in the beginning, those who were vaccinated were doing far better than those who were unvaccinated. Hospitals were full of people who were unvaccinated and hardly anybody who had been vaccinated. So passive immunity happens.
Sorry, White House says we could see 100 million COVID infections this fall. Hyperbole or reality?
I really can't answer one way or another. To David's question about making predictions, we are seeing variants. I think across the world, we're seeing some changes and we're seeing some uptick, although I think the key again is severity of illness, recognizing that this is something that we're going to have to live with. So we're going to continue to see infection rates. It really depends on how severe the illness is and how it impacts our communities.
A British study found people with severe COVID who receive critical care in hospitals experience aging of 2 years or loss of 10 IQ points.
Yeah, so we're seeing this, we're hearing about this, and again, Dr. Brown and I were in a conversation earlier this morning. We talked about long COVID, and there's a lot of mystery around it yet, a lot of research, but it's concerning. And yeah, this brain fog, the neurologic symptoms seem to be some of the most worrisome. And this loss of IQ has been documented. And the question is it permanent or is it temporary?
Okay. A friend was hospitalized with COVID and now has major brain fog. Is it more connected with severe cases or could it happen to anyone?
I think this is a question that's up in the air. Again, we're still studying it, and at this point, it appears to happen to anyone.
According to CDC, BA2 is now up to about 36 of all cases and up 10% from previous weeks. Please elaborate.
Yeah, so this is the same phenomenon that we've seen all along with the new variants. A new variant becomes an issue because it can spread more easily, more quickly than the one that was there before. And so it makes perfect sense that it's going to overtake in percentage simply because it spreads more easily. The other question we have, well, does it make people sicker? And so far, keeping our fingers crossed, we're not seeing that, but it is spreading more quickly.
Are BA4 and 5 still outside the country?
So we have seen a few cases of 4 and 5 in our country. The key again is severity of illness, and we're not seeing that there's a significant contribution.
Is BA2 being called the son of Omicron, or is this another one?
Yeah, I know this. Well, so with the BA1, BA2, BA2.12.1, BA3, BA4, BA5, I mean, these are all children of Omicron, I would say, but yeah, it's all within the Omicron family.
Is there any location in the U.S. that has COVID under control? I'll emphasize control.
I don't think we can put it in terms of being under control. I think for instance, for our region, we currently have lower numbers than we've had in relationship to previous months and years. But it all depends on, as we spoke on in the beginning of this conversation, it depends on what the variants look like and what's coming our way. So I don't think we can make a prediction that says we have anything under control. I think that we're stable right now.
Last question. Contrary to what we've been hearing, a large U.S. study claims Omicron may be as severe as previous variants, though the hospitalization risk was less. Is that the final answer?
So I doubt that's the final answer, but what the observation is that the people who were infected with Omicron, if they had some pre-existing immunity, whether through vaccination or through a previous infection, that they probably were not getting as sick. So the question is, the people who had no immunity whatsoever, were they getting just as sick as the people who had wild type or alpha? And so this is not the final answer, but there is some debate about that.
It's ongoing. I want to thank you for joining us for COVID-19 Talk with local health authorities. Joining us was Dr. Erica Brown from Harris County, Dr. David Pearce from the City of Houston. Special thanks to our co-producers, David Castillo and Morgan Ash, and a very special thanks to Kathy Finninger, past president, Rotary Club of Houston. I'm Stephen Williams, director of the Houston Health Department.